Hi, my name's Emily Largent. I'm an assistant professor of medical ethics and health policy at the University of Pennsylvania, and I will be talking about monitoring on your mind, which is one way of thinking about how we might monitor the minds of older adults who are at increased risk for developing dementia caused by Alzheimer's disease. So in terms of background, for a very long time, when we thought about somebody with Alzheimer's disease, we thought about somebody who had dementia. An older adult would present at their clinician, and they would describe a characteristic pattern and onset of symptoms, loss of cognition and functioning, that were affecting their everyday lives. So based on what they heard, the clinician would say the most likely cause was Alzheimer's disease, but that would be a probable diagnosis until the patient died, at which time an autopsy could be conducted if the family wanted, and they could find out definitively if the cognitive impairment experienced in life was caused by Alzheimer's disease. Now, as it turns out, there's been a recognition that Alzheimer's disease is a public health crisis, and with that, there's been a huge investment in the science of Alzheimer's disease, trying to understand both how we can find disease-modifying therapies, but that has in turn required that we understand the neuropathology of Alzheimer's disease. So with that, what we've seen is we have now been able to identify biomarkers of Alzheimer's disease. These are amyloid plaques, tangles of tau protein, and neurodegeneration. And as a result of this, we can now take apart those two strands I talked about, dementia and Alzheimer's disease, and we can in fact tell people if the changes characteristic of Alzheimer's disease are happening in their brains while they're alive. And in fact, we can start to see those changes years or even decades before the onset of cognitive impairment. Now, this stage where somebody has the neuropathology, but they don't have cognitive impairment is called preclinical Alzheimer's disease. And those individuals are at an increased risk for developing mild cognitive impairment or dementia as they grow older. Now, along with this biomarker science, I mentioned amyloid, tau, and neurodegeneration, there's also been interest in digital biomarkers of Alzheimer's disease. And in these cases, we're able to use technology to see if older adults are at increased risk. And just to give some examples of how we might measure that, it turns out that changes in your driving patterns well before you're cognitively impaired, maybe you're driving under speed, maybe you're staying closer to home, suggest you're at increased risk. Early changes can occur in your finances. Are you uncharacteristically missing bills, making late payments? These can also be indicative. And it turns out there start to be interesting changes in your home, even in terms of how long you leave your refrigerator door open. People at increased risk for cognitive impairment tend to make more trips to the fridge and they leave it open a little bit longer, possibly hunting around for something that they can't find. Now, all of this suggests great potential to find individuals who are at increased risk, but we have some challenges that we have to think about in this case. One, we have to think about whether or not people want to know they're at increased risk. In research I've done with individuals who find out they have preclinical Alzheimer's disease, they suggest that this information is actually qualitatively different than other information they learn about their health and well-being. And that's because they see Alzheimer's disease not just as a disease of their brain, but of their mind. It affects how they interact with the world. It changes their identity. It changes their interrelationships with other people. So we have to think about consent. We have to think about desire to know the information. We think about how to return the results. So far, we aren't returning this piece of information to people clinically. Instead, we're actually doing it in research studies that are very carefully structured to make sure that people understand what the information says and can't say, and that they are able to take that and use it in ways that are meaningful in their own lives. Because we don't have drugs or treatments, that typically is updating wills, revising advance directives, identifying surrogate decision makers. We also need to think about what are the obligations of non-health actors who now have this very important piece of health information. Traditional privacy laws don't apply here, but how would you feel if your auto insurer called you, your banker called you, and if your fridge alerted you that you were at increased risk for dementia? So how we communicate that's going to be important. How we think about protecting privacy is important, particularly given that these are potentially vulnerable older adults who might be at increased risk, say, for abuse or financial exploitation. So what is one thing I'd like people to know about this area? Well, preclinical Alzheimer's disease is still a research construct. That is, it's not being used in the clinical space. And that is, as I mentioned, because we don't have a disease-modifying therapy and we're still trying to validate that. But the technologies I've described so far are in the world. You can go to Home Depot and buy a smart fridge. Many people already have a device they plug into their car from their auto insurer that sends information back to the insurer. Banks already have systems to monitor for fraud or strange transactions so that they can go back and alert people and make sure they're preventing problems. So what we have now is a good evidence base that these sorts of pieces of data are indicative of dementia risk, and we already have ways to measure it. So what we're seeing is that the science for monitoring your mind in the community or in your home is far outpacing the clinical science of dementia care. And so we really need to think about what we're going to do with that gap between the clinical piece and the digital monitoring piece. And what's my prediction for how this area will progress, or what I would like to see happen in this area? Well, ultimately, I hope that we can work on destigmatizing Alzheimer's disease, educate people about this information, and when they get information about dementia risk, be it from their banker, their insurance agent, or their fridge, that they understand what the next steps are. Hopefully, soon that will mean taking a disease-modifying therapy that reduces their risk of developing or even prevents the onset of cognitive impairment caused by Alzheimer's disease. But to be most empowering, to respect people's autonomy, they need to understand what they can do with it. And that is teaching about interventions like updating wills, advanced directives, finding a surrogate decision maker. We need to build capacity in our clinical system to care for people who find out in these unusual routes that they're at increased risk. And we really need to work on creating new social narratives to support people with dementia and address the needs of caregivers. Because even if we have these sorts of detection, we have an over-reliance on informal caregivers, and we have a system that's not really equipped to care. And so we need to work on all of that.